So when we're dealing with this, we're going to basically kind of talk about the etiology, go over stable and unstable, talk about signs and symptoms, what we're doing treatment-wise, and that. So when we're getting into this, we're basically going to ask the questions, kind of go over everything with angina, because what is our typical presentation of angina? Is it a heart attack? What do you guys think? Not always, right? Can it relay? Some people talk about angina can progress and get more and become into a heart attack. A lot of times what we think about this is we're talking about angina being something that occurs with activity and it decreases with rest, and it's some strain on the heart. So whenever time we get this and we talk about someone who basically had some chest pain with exertion and now is resting, don't just think it's angina. Let's ask the questions. Let's find out what's going on with this specifically, because there's lots of different reasons they talk about chest pain. So we're going to look over the, bless you, the etiology for chest pain can be wide in variety too, right? So what are all the potential reasons for having chest pain when these patients are complaining? Lots of different things. So we got to look, is it a respiratory driven? Is it a cardiac driven? Bless you. Is it a GI driven? Where's the symptoms? Because what did we just talk about with the GI system that can relate to chest pain? Yep, gallbladder, cholecystitis, everything like that from after eating fatty meals. So be checking out those areas. Musculoskeletal, is this pain with palpation? So is it something that I can press on there? Is it positional? Is it all those aspects? So don't just get tunneled in on everything. Start asking the questions and rule out. Come in with lots of different things, because when someone complains of chest pain, it can be tons of different reasons, right? So be thinking about all the aspects and what you're going to do to rule it out. Hate the long slides. Be looking for different aspects that can cause for it. And if you get the 20-year-old male with chest pain, is that a cardiac arrest? I mean, a cardiac incident. Cardiac arrest, not a cardiac arrest. Is that a cardiac incident? Majority of the cases, it's not, right? It's not directly a heart area. Can it be? Absolutely. We see all the time. There's no such thing as always never. But start trying to rule out what potentially could be in there. Find out what are your norms that are in there. But find out what's going on with it and do that etiology. So different areas in here too. We have what's called zones of ischemia, injury, infarct. We call these areas also penumbra when we're dealing with stroke, as you guys are going to get into any injuries or zones of infraction that are going to be infected. So when we get a spot where we get an area of ischemia, it's basically a death to the heart, death to the brain, other aspects that we're coming into, the cellular level. And then you're going to have basically an area that surrounds that area that's affected. Some of that ischemia can be permanent, some of it can be temporary, depending on how long it's getting lack of blood flow to whatever organ it's dealing with. In this case, we're going to be dealing with the heart. So you can see we have a couple different areas. So we have the zone of infarction, which is basically the area where we're actually getting loss of blood supply from. This is usually an area too where we can get permanent defect from. When people have a heart attack over a period of time, they usually get scarring or a loss in a specific spot. Pretty common on here. Then you get a zone of injury, which the zone of injury is outside that area that comes around that. And then the zone of ischemia, which is this outside area. I don't want you guys to memorize the terms. I will not have the terms on the test for you. And if Gary puts it down on the test, I will take it out, that question. So you don't need to know the names of those zones. But what I want you to know is usually the central portion is the injury. The other portions that come out are usually reversible. It just depends on how long that area goes ischemia. The longer it goes ischemia, the zone of injury becomes the zone of infarction. The zone of ischemia becomes the zone of injury, and vice versa. It basically just keeps growing out. The other aspect of why this is important is the scarring tissue that are down there. So once you get scar tissue or an injury to especially the ventricular area, this can eventually lead to starting its own beats at a certain period of time. Injury to an area where it forms scarring, it can actually become its own center, bless you, of starting its own autism. So we'll find people with new onset VTAC. If you've trying to rule out that versus SVT and some other things like that, you ever ask them if they've ever had a heart attack before. If they've had a heart attack before, most likely it's VTAC. because now that area of scarring where that injury was before is actually leading the beating, causing the ventricles to beat out. So some of these scarring tissues down there will cause problems. Yep, and it can actually start the conduction from them, from an injury and being exacerbated. So different pathophysiology that you're going to see that can cause this. Obviously, you can look through these signs and lists and see these are all different aspects that can cause injury to the heart. None of these should be new to you guys. As far as anything, this is nothing new information-wise there too. Arthrosclerotic plaques basically can cause a lot of this too, that are causing blood clots and different factors that can cause temporary disruptions to permanent disruptions to flow to different parts in the heart. Our risk factors: obesity, recently eating a large meal, exertion, hypertension, smokers are going to be big, diabetes, cholesterol, stress. All these factors, again, shouldn't be anything abnormal or new to you as far as what can cause these and lead to aspects. What's that?
You just described firefighters.
Yeah.
Obesity, large meals, hypertension,
Some case. So there's different aspects. Angina is almost called Priesmantel's angina. Basically, this is a normal spasm of the coronary artery, which can cause a temporary loss. This is normally something that's coming with periods of activity in areas, and it can basically cause a spasm in the artery, it causes a constriction and causes loss of blood flow. It's a temporary aspect. You take off the work of the heart, the patient rests, relax for a minute, that spasming stops, gets blood flow back to the areas. It usually happens in the different coronary arteries, and again, it's a temporary, and that's usually we talk to people is, did this come with activity? Did it come to something that started it on, and then a period of rest that it came through, as opposed to if you get a sclerotic plaque coming in and it blocks the area with activity, that plaque usually doesn't disappear with rest. So that's going to be kind of the difference between an MI, myocardial infarction, versus a temporary from a spasming aspect. You look like you have a question, Trevor. Okay, just making sure.
Thank you. Ask what it is. For somebody else to ask it.
Going.
Come on.
Okay. So, again, they throw this off. I hate probabilities because as soon as I tell you that angina, especially Priesmantel's, occurs more in younger women, you're going to see it. I've never actually seen this in young women. So I don't know where they come in. Again, they talk about high probabilities, and there may be a high probability of seeing this. I normally see angina in middle age is where I see most commonly. And I've seen it in men personally more than I've seen it in women. That's just my personal area. So I have a hard time going with how these present. These can actually come associated with and can actually cause ST elevation. Why would they cause an ST elevation? Because it's actually causing a temporary ischemia to the heart. It is going through that vasospasm that can come in. It can actually present at that, but it usually will go away. But there is a blockage of flow temporarily from that heart being overworked, and the arteries will spasm, contract, and have a block with that exertion of being overworked. Correct, because it's temporary. It's not a permanent type of injury. So it's a wave. It's what we call a penumbra in the stroke area. It's the same thing in here. It's that zone of infarct that's coming, but it's a temporary, that's injury to it because it's just a temporary aspect. It goes away. And a lot of times it doesn't leave a scarring.
If we get a patient with that, and we give them nitro, they start feeling better, do another 12 weeks, the ST elevation can be gone. Or
Most cases. What's that? Yep. You give nitro in any case if there's area and you open up those arteries, basically it takes off the spot and you don't have those areas. So it can happen on those. So it may be accompanied with that. It's just another aspect. Angina can be classified as stable and going to unstable. Basically, unstable is basically same type of thing. It's where it's progressing and becoming more difficult. Your patient is having pain, but it's the symptoms are getting worse. The pain is lasting a little bit longer. It can still be an angina, but it's progressing as far as how long the episode lasts, how long they're getting those areas in for. It's still not fully what we considered an MI and a full blockage on there, but it's getting close and it's progressing. I've had some docs tell me that angina does not mean that they're going to have heart attacks on there. I disagree. I think they can progress and they can go up there. There's always factors to that. And I think anybody who has angina type of pain should be evaluated by a cardiologist, in my opinion. If you guys see it out there and you feel like, yeah, it came with rest, I think they should be seeing a cardiologist, because I think these can't progress. And this talks about a stable angina patient over a period of time can become more unstable, because as they get this, those temporary zones of injury can start to become more permanent too as well. So these can progress, in my opinion. Normally, again, when we look at a stable angina, these are patients that the activities come when they are having activity associated with it. So they're becoming active, they're doing that, and then with rest, they stop. Unstable, we're starting to see even at rest. They can have minimal exertion. It's not taking much to get these things to start. So they start happening more frequently. We can usually get them to resolve pretty quickly, and we can take care of those issues, but they're starting to happen even with minimal exertion and pressure on there. And now as they kind of talk about it, you sometimes can get elevated cardiac markers that pop up that start getting there, because you're starting to get damage to more of these heart. It's becoming more and more progressive on there. Still not considered a straight MI, and most of these areas, you're not even going to see the ST elevation with them. So this falls almost into what we call our non-STEMI type of areas that pop up. But these treatments, again, going more and more commonly out there, we go, okay, you got angina, you're taking nitro, you're going to be fine. We sign a lot of release on these patients. Be making sure that they're following up their cardiology, because cardiologists, and if they're not seeing one, they need to be, because these can basically progress, in my opinion, quite a bit into more permanent areas. And then once they get to an area where they cause a permanent damage to the heart, they can lead to a lot more ventricular type rhythms that come up, like I talked about with VTAC and other aspects of having injury in the, what do we call it? The automaticity of the area is basically starting from a ventricle lead, building up and causing reactions with these. So that's kind of an area that I want you guys to be watching with these, is if they have it and they're angina and they're resting on that, make sure they are following up with a cardiology. Does this patient need to go into the hospital for the ER? No, and not most cases. But you need to be, at least if you're signing releases with these patients, making sure that they are going to follow up with their cardiologies, because these can progress. The signs and symptoms with these basically are going to be almost exactly to an MI, right? Look at the signs and symptoms up here. Differentiate those from someone having an actual MI. They're exactly the same, right? So it's your job to go in there and try to make those determinations of what it is. What caused it? Well, look at these. Is there anything different here that would be different from a standard MI? No. So basically, these can come in here. So what's going to be your differentiation to tell the difference between these and what's going on with an MI? EKG is going to be one, which we talked about in some cases, can be there. So you want to go in there, and the big thing is where I'm going to start off with, number one, get a good history. Find out how it started in front. That's going to be one of my first determinations. If I do an OPQRST, am I going to be delineation this between angina and an MI? Not necessarily, maybe, but it's a good start to where I'm going to go to. But also in that, I'm going to get that history and goes, have you ever had something like this before? Has it been coming on? Yes, I've had this before. What normally happens for it? I normally take the stop and rest, and it goes away. I can find that in my OPQRST. If there is a area where they're having chest pain and it went away with rest, what's my number one diagnosis? What's my top of my differential? Angina is usually it. So a lot of times I can differentiate from that, but I may not be able to. So go in and look at their skin signs then. Has everyone seen a patient who's had angina? Anyone have it? Maybe not, Matt? Okay. So look on them. You can tell a difference for these people, especially when they start relieving. How they look. Do they look like they're having a heart attack? That's the next thing. So ask the questions and look at them. How are their skin signs? How's their work of breathing? What brought it on in the first place? You're going to get your set of vitals with your 12 lead. And that way you can see on there. But like I said, in some cases you may see an ST segment elevation, but it's going to be brief. Make sure you do follow-up serial 12 leads. Big thing is here, did it change with rest? That's our #1 area from a standard angina. But as they get more unstable, that may not be the case. So you got to start doing a little bit more detective work with this. Look for your exam. Look to see if they have any signs of scarring or previous heart injuries. Look to see if they have any JVD. Any other things you would see that you know you're going to find it on with an MI. Check with this and be asking those questions. These are typically areas that we can come in, and the biggest thing you're going to see is these patients, the pain definitely came with exertion, some type of activity. Normally they haven't had this before. It's only been 1 or 2 times. Ask if it's progressively gotten worse or not. But once they've rest and once they sit down, the pain goes away. It's pretty easy standard diagnosis for that. Does that patient need to go to the hospital? What's your opinion?
If it's undiagnosed, I would.
Absolutely. They've never had it before. If they've had it before, they need to go to the hospital?
I'd recommend it.
Okay. Jake?
I would say.
Laban?
They know their history, how's it line up with their history?
So those are areas to go there. So if someone has angina, they've had it in the past, our recommendation obviously is they should go in, but do they have to go in? No. But make sure they're following up their cardiologist, especially if they've had these a couple of times. Make sure they're following up with the cardiologist. That's the big thing. But those are ones you can have there. But again, our recommendation is always going to be cover your butt. Make sure they go in because you don't know. Make sure you're doing 12 leads on these. Make sure you're doing a full workup on that. And does this showing symptoms of a heart attack, or does it appear like everything's resolved at a period of time if you are going to sign a release? Fair enough?
You'd expect that once their heart rate, I mean, the timing of rest, their heart rate.
Once the pain's gone away and they've had no things, and again, the difference is, and Christina made a great point, is if this is the first time, absolutely they need to go in.
But
They
from
need to be evaluated.
after
But
exertion, it takes their pulse
oh
rate
yes,
getting down.
how long did it take? Have they been resting for 10 minutes and it's completely resolved and all the issues are gone? Yep. And if they've had it before and they know histories of this and they've done this, you can sign a release on those patients, in my opinion. One person's opinion, remember. But be making sure they're following up with their cardiologist if you do not transport that patient. First time they've ever had it, make sure they're going in because they need to be going in because they probably don't have a cardiologist in that case
Or
too.
if it's changing, like if it used to take them 10 minutes and oh, I feel better.
Progressively getting worse.
Now
Yep.
it's like 30
And
minutes.
it's converting from stable to unstable.
Yeah, if they got history, why did they call us this time?
Yeah.
Maybe like wife freaks out or something. You know, family
That's
never seen
most of the
it.
cases. It's not necessarily the patient, it's someone else.
You're at a store. And
Sure.
Yeah. So, history on this stuff, again, just kind of keep looking through these questions. This is a good list of questions for you guys to be putting on your radar to ask. So you can come in through. I'm not going to go through all of these specifically, but basically think about all these questions that are up there and what causes can they have? And what are you going to do based on the answer of these questions? That's the other thing that I want you guys to get used to as you guys are, for those of you who are riding with medics that are out there and you're going on these calls, listen to your medic's questions. Or if you're not with a medic and a medic comes on the ambulance, listen to that medic's questions. Try and be around as much as possible. Even if it's, I know AMR will sit on scene for a little bit to get information. They got to pick up over things. They'll stabilize. They'll do those. Jump in the back. See if the medic will come in there and just sit in the back and listen to some of the questions they're doing, because sometimes it's easier to get the patient in the back and ask questions in the ambulance than it is outside. Listen to the questions they do, mentally think about it, and if you know that person or get a chance, ask them why they asked a question if you don't understand why. And that's where you guys are going to learn about this stuff is, okay, I heard you ask the patient this question. Even when you're in the back, if it's, again, as long as your patient's stable or you talk to them later, ask them, why did you ask this question? And then more importantly, what were you going to do if they said this, and what were you going to do if they said did this? That's how you guys are going to learn and build on. So with these questions, if I asked on there if they've got any thyroid or hormone changes or anything like that, why is that important?
maybe the medication.
Well, we already talked, remember when we go back to the hormones and how everything, those regulate our entire body systems, right? So we get hormonal changes, those always can affect our heart beating, they can affect rate, they can affect so many different things. So what was the change? Is there a change in medications? Is there something like this that went through? So you can try and say, okay, is this related to this, or is it cardiac? all those different things, but start learning about these questions. These are great questions on here to be asking on there, and then figure out what you would do based on if they said yes or no. You guys, we haven't really got into ACE inhibitors yet and what they do we? Or MOI? Okay, sorry. Forget I said anything. I'll take us there in third module. I don't want to cause more stress. Okay, so and then when we do our assessment, basically we're doing our same assessment as we've done with everything. We're going to be asking our same questions. We're going to be going 12 lead. Obviously, we haven't done 12 lead yet, but basically what we're going to be looking for is we're going to look quick lead on there. If you talk to Dr. Steve Edmister, he's going to say all you need to do is look for, is there elevation, is there depression? Talk to Joel Edmister, he's going to say, is it right axis, is it left axis? Dr. Raby's going to see that. What segments are going through, and we're going to talk about other things that are coming too. So is this a strain, is this ischemia? Is this an old issue or is this a new issue? We're going to talk about their presentation, what had happened, what else is going with it. Is there associated symptoms with this? Is this isolated chest pain? Do they have any feelings with it? Again, no different than we kind of talked about earlier today as far as asking your general assessment. The big thing I want you guys to get to is you guys have got to ask better questions, more questions, and make sure your questions are pertinent to the situation and what you're going to do with that information. And realistically, the whole purpose of your questions should be to develop this differential diagnosis and weed it down to what you're doing. So now you've asked the right questions, you've done the right assessments, you've checked the right vitals. Now what are you going to do? You're going to find the right treatment, right? So, and I'm going to tell you too, is we're going to get into some documentation series. This is how I'm going to teach you guys how to document the way we want you to document. Sounds funny. How many of you guys right now currently write PCRs? Okay, everybody. Mostly. Yeah, some departments, it seems like the medic does all of them, some not so much. We're going to show you the way we want you to do the documentations, and it's going to go kind of the philosophy that I just went through here. When I go through, because I have to get to read all your guys' chart notes that come through, you guys are going to give me a history. And in that history, you're going to paint a picture for me. You're going to tell me everything you're going. So you're going to ask all the questions, and you're going to write them down. You're going to tell me what's the past medical history is. You're going to tell me what their meds are. You're going to tell me those. Based on I see that history, I'm going to say, okay, I bet you they're going to do these assessments. So I'm going to go look down your assessments. So I better see your assessments that you assessed the cardiac system, you the respiratory, you did the musculoskeletal, you did the endocrine system or whatever applied to that. Then based on what I see from your results on your assessment, I'm going to see in your treatments what you did. So on here, what's our treatments for angina? What else? Rest. What else? It's basically going to be everything that we do in most chest pains. Aspirin?
Yeah, sure.
Absolutely, because they were complaining of chest pain, right? We don't know initially when they're complaining if this is an angina, is this a temporary attack, or is this an MI? So we're going to treat the statement just like we did before with that cardiac patient. We're going to treat them through every aspect. So SpO2, they're saying here again, less than 93. My philosophy, less than 99. Some form of oxygen is never going to hurt them, especially if they're in there. We're going to get a 12 lead. We're going to treat each of these patients, even if we think it's angina, even if we've got a history and everything like that, still do a 12 lead. You're going to take this patient in and get a blood draw on there. I'm going to kind of defer this to some of the AMR people to see what.
Just draw labs. I mean, it's awesome. It was just Sacred Heart that had that moment of.
Yeah.
Just draw labs.
So
awesome.
every time that I do an IV now, yeah.
What? Here's the
They had a moment, a freak out moment.
Yeah, they were like throwing away the tubes and everything like that. So
If they want, throw them away.
Then throw it away.
Yeah.
Just time them. Just
So,
put a timer on them.
here's my aspect with that. If your patient is complaining of any cardiac issue, certain respiratory issues, if they're septic, any of those type of things, draw bloods anyway. Now, there are cases on there, and I think, sorry, when I wink my eye, it's not I'm winking at anybody. I had LASIK surgery, PRK on one eye, so I can't, so I'm over here. If I do this, I cannot see you. If I look this, I can see you. So it is not, I apologize. I do this a lot here. It's, I got to get over it. But well, I am, Craig. Yeah, you just, Scuba Steve just got me excited. So. No, so I talked to several people. Sorry, I'm going off topic. Gary had LASIK done or the PRK done too. If I do it on both eyes, then I lose my nearsighted or my farsighted vision. So he has to wear cheaters, and most people have to do cheaters. And I didn't want to wear cheater glasses, but I don't want to wear glasses for vision. So this eye is fixed so I can see distance, so I can see here, but I can't read up close. So if you catch me doing that, I apologize. That's what I'm doing. This is reading. This is distance. So I just have to say that so you know I'm not winking at you, Christina. So long term on that. So, yeah.
So, but like we don't draw blood like for labs and stuff down there.
Okay.
What is the reason that AMR and whatever else does?
So it's a timing issue, and they may draw bloods again too. But so right at the incident, what happens? They have information so they can run labs off those. And
But they don't run labs in the ambulance. Right?
No. No, you take it and label it, and then it's when the hospital. Now it's that much quicker. They can send those right to labs.
Gotcha. So it just saves that step.
Correct.
Gotcha.
Yep.
Okay.
Okay, I have kind of a dumb question. So, just because we don't draw labs either. So, nitro and aspirin, are those going to affect your labs very much? So, you can give the nitro and aspirin and then draw labs with them?
Correct.
Okay. And
Yep.
It's not gonna,
And-
so, you don't want to do too many other interventions or it's going to negate your labs. So,
Well,
right?
normally what it is before I can do too many interventions, I have to have an IV established,
Right.
and I pull it right off before I even put a line in there. So it's probably one of my earliest things done. The other ones is strokes. And again, I've had different hospitals tell me too, and the AMR people can correct me if I'm wrong. The green tubes have a special area they draw, and some hospitals like it if I draw 2 green tubes on stroke and cardiac.
They like the 2 green, actually.
I've heard stroke and cardiac,
I
but
know definitely cardiac, they
Give
like the
one.
2 green.
They waste more
But-
time, they give one.
yeah. So, but basically what we'll do in most cases, now I've also had a couple of cases and did one with Christina where we could only get a 24 in. Actually, 2 different cases.
I went back on her, by the way.
Yeah. So we've had 2 different patients. One we got a 22 and one we get a 24. Well, I couldn't pull, it just didn't have enough to get labs drawn out of there. So certain cases I want labs, but I can't get any blood out of there too. So yeah.
What's the time frame to where you're too far extended out to be able to do those tests?
30 minutes, right?
I think they don't throw them away after an hour, I think.
Yeah.
I think an hour.
I specifically don't know.
I just know that that's right, the time frame. You know,
So is there I don't know what the term is, but is it a better thing to draw them early like that? Is that why they want them?
Well, they can test it because then they can do it at different polls. They can do they'll do an art line. They may do something else and pull labs later.
So it might show something early on.
Could show something.
Something different later on. Oh.
Yep. And they're changing, like I said, so the CPK levels can change within 6 hours.
Whatever that is.
That's the markers for, it's not strip, it's
It's not black, like carbs and gas.
Yeah.
Yeah.
creatinine phosphate markers, yeah.
Everybody here knew
So-
what CP was.
Yeah. So there's different markers that come up on there and showed up on time, and some of them won't show up. And basically what it is, it's a marker of muscle damage. And whether it's cardiac muscle, whether it's rhabdo has different all different things, but there's specific markers to cardiac muscle. Sorry, I have to play with things. So drop my pen.
You wink at us and play with them.
I weak at you. That went south real quick there. Okay. All right, so moving on. So we're going to make sure that we're going to do these things as far as asking our questions. Remember, always be checking blood sugar because blood sugar has so much different effect on the body and everything else too. So treatment-wise, obviously we're going to do aspirin. We're going to do nitro, usually the sublingual. They've got sublingual sprays out there in certain areas. I'm not familiar with those. And then again, if your patient truly is in pain or anything else resolved by nitro, we can use morphine or fentanyl. Besides District 4, I don't think anyone around here carries morphine. Do you guys? Okay. Do you guys morphine over there? No. Okay.
Does it work? Vasodilation?
I don't know specifically. I don't think it does specifically, but I'm not. I'd have to go back and check.
So Lauren says that it has
Properties.
And that's where for the MONA, that's why
They prefer morphine.
yeah.
Yeah.
That's
I-
like secondhand information.
Yeah, I don't know specifically.
I feel like I've heard that somewhere.
Yeah, it has the pain first and then the dilation second. But don't have to be like specific.
Yeah.
Like that, sorry.
So as far as treatments for these, besides those, transport decision, determine on where they're going. Obviously, if this is not relieved itself, or this is first time kind of we discussed, you're going to transport. It's determining out what you're going to do. You know, is this brand new symptoms? Is this progressing symptoms? As a determination. Not every person, because they call 911, has to be transported, in my opinion. Yes.
Sorry.
But it depends on who you talk to. I know certain medics who you call 911, you're going to the hospital. It's not a bad philosophy. Again, who here is a doctor? Okay, right there? Okay, so we got there. So you can take that liability on. That's the hard part that you always have to go to is, again, it doesn't go on our liability. It always goes into the physician we're working on. So I'm never going to make a call out there on an aspect of something because I could be put in a liability. So if there's any doubt in my mind that this could be something else, they should go to the hospital, right? But fair enough, we all get the people, and I'm looking at you specifically, yes, because I know how many people you get in that area who call who don't need to be going in. I get it all the time. I'm not afraid, but basically when you fill out refusals, we'll go over specifically. Refusals should actually be your most detailed chart note. And it should actually have the most information of why you felt this patient didn't need to go to the hospital. And again, who are you writing that for? You're writing that for the jury.
Usually the refusals, we're telling the patient they don't want to go. So we write the refusal saying, we suggest you go.
Oh, absolutely. Oh, absolutely. But again, we're telling them, so we put in there, told patient needed to do this. We're documenting that we requested, not that we're saying they don't need to go. Because if the patient says, I want to go, they go. Yeah. In my opinion.
No, I just the way you worded it.
Okay, I apologize. Yeah. No, so it's basically when the patient says they don't want to go and we think they should. That's our most detailed. But the point I want to get into as we get more into documentation too as well is I want your guys' notes to almost look identical because that's the first thing they'll do. We're going to be doing a EMS Live on a mock trial on documentation. So where I want to get on focus with this too is because have any of you had to get pulled in for a jury on any calls yet? Most common ones you guys will be getting pulled onto is DUIs. Yep, you guys will be, especially if you're being called to do blood draws or you're anywhere associated, you will be called into it. They will look at your documentation, but you want to know what they look at when they pull that documentation? Partially, yep, but they also pulled 10 of your other charts. And they look, are your documentation equal or did you spend extra time on that? So they will pull different ones. They'll go, I want 10 different reports from this person up there. And they'll look, if they're pretty equivalent on there, they'll go, okay, yep, this is accurate. If yours is different, they will use that. And again, these defense attorneys are really good at that because their job is to get their client off. They'll say, nope.
Slimy.
Well, they're very good at their job. We'll leave it at that.
Slimy.
So,
How do they get around it then? You're pulling
easy.
Documentation.
It's called a PIN. Knock out anything that can identify that patient. Anything that says male, female, age, name, which we don't have names on.
So it's good to have them all look the exact same.
Absolutely.
Just the different.
So that's where I want you guys to get used to an area because,
everything's caps.
yeah, so I want your documentation charts to go through. Not that I'm recommending you guys use templates or forms. I know a lot of people use templates that are out there because you don't want to look at too templated either. Problem with templates is people don't change the template, and I've seen that before. And all of a sudden it comes back and it says something on there, and it's like, wait a minute, that contradicts what you said here. So that's why I recommend you don't use templates. Here's again, just talks about the refusal, which we did already. So it just kind of, again, determining on if that patient needs to go or not. Questions? No? All right. So let's take another 10-minute break, walk around, and then we'll come back and we'll do cardiac tamponade and pericarditis.